also known as the safety cases, which you can't miss it. Another thing is MDT, that is very important part of the NHS structure, that is
Recording in progress.
multidisciplinary team meeting. In that multidisciplinary team meeting, what happens is that you need to take consideration towards the various clinical pathway. So there will be a clinical question and you need to direct towards the some clinical pathway. For example, patient has some abdominal pain. Now you have to develop some findings and divert it towards maybe surgical pathway, maybe medical pathway, maybe vascular pathway, something like that. So that's why this viva structure exists, and they want that kind of the findings only. So, whenever you are giving Viva, you need to be systematic. They want you to be a systematic approach, which includes observation, interpretation, differential diagnosis, and management. This should be the structure whenever you are speaking. And there are certain things which you need to take care of. You don't need to be a scattergun approach, means you don't need to speak long. You are not allowed to miss any safety finding. You need to develop a habit to go ahead with the safety finding. You have to check them. And always, last and not the least thing is that you have to follow a structured approach, and finally you need to conclude your viva with the management. So these are important things. And another thing is, whenever you are giving answers, whenever you are look at this screen, first always observe the case, take the time, tell the examiner that I will have a few minutes to look at the case, and then start your viva. That will create a better impression that you are not hefty, you are a safe radiologist. So main aim is to become a safe radiologist. And that's why this exam structure has been in place. So now we are starting with candidate one. Who is candidate one? Are you here?
Good evening, sir. Yes, I'm here.
Okay. What I will do is I will share my screen, and whenever there is a need, I will ask you to take a control. Okay. Otherwise, you don't need to take a control. Whenever you feel that the things are not clear, you can ask me to zoom in, zoom out, something like that. All right. So I'm
Okay, sir.
sharing my screen here, and then we are moving ahead from that. So, candidate one, this is first case for you, and you can take it over.
Um,
So the first case, I would like to give you a bit of clinical detail for that. Every case will be having clinical detail, and then we will move ahead. The, a child present with a right-sided limb. Please go ahead, candidate one.
this is X-ray pelvis frontal projection in a pediatric age group patient who presented with limb. In this X-ray, I can appreciate that there is a decreased height of right femoral head. There are also some prominent subchondral lucencies seen on the right side. And if I further see it on detail, the epiphyseal and metaphyseal junctional region is showing a bit of sclerosis and loss of growth plate. The acetabular roof is showing sclerosis as well, along with some irregularities in its margin. There are few loose bodies seen, foci of calcification, you can say, in the within the joint space. I believe that this is a, a long-standing process, not very acute. The associated fat planes are not blurred. There is no significant swelling. Although if compared to the left side, there is a bit more swelling in the soft tissue on this side, but doesn't look severely distorted. If I come towards the left side, I can appreciate that there is a bit of irregularity on that side in the medialmost part of the femoral head, but the height is maintained and the joint integrity is maintained. The right side, I would like to comment on one more thing, that there is some angular deformity in the neck of the region as well. I would like to take a picture of this the history if the patient films as well, because in that scenario I would like to compare with the previous one to see the progression of the disease. It looks like a case of avascular necrosis with degenerative changes. And if the patient has the MRI has not been done before, next I would like to see the MRI. So my diagnosis based on this case is Perthes disease with secondary degenerative changes and some deformity of the femoral neck. And next, I would also like to see the previous film and advise MRI for further management.
All right. So what we'll do is we are taking cases first, and then in the end we will discuss them. Okay. Yeah.
Okay.
Second case, and for that you might be needing control. So if you could ask me for control.
Yes, sir, I'm requesting control. I've requested it, sir.
And your history is it's a 75-year-old female with an acute onset of abdominal pain and distension.
Okay. So just give me a sec.
Take your time and no problem.
I don't know why it's not scrolling. Yes, it has started.
It will,
Sir, I would like to start
yes.
from the beginning. So this is CT abdomen in a 70 years old female patient in which I would like to take a moment to scroll through entire stack. Okay, sir, I would like to start the case now. This is in this axial contrast enhanced CT abdomen in an adult patient. I can appreciate that there is portal venous gas. There is adjacent to liver. There is I can also appreciate ascites. The gas is portal venous because mostly it is branching in pattern and it is reaching till the periphery of the liver, and moreover it is less common, less concentrated within the central part of the abdomen. The gallbladder is a bit distended with might be sludge or fluid. There's some heterogeneity seen within the porta hepatic region, and there is distension of abdomen as well. In the region of there is extensive calcification with a filling defect seen in the region of superior mesenteric artery, I think, and there is some distortion adjacent to it as well. There's an air focus adjacent to it, which is, I would like to follow this. Mm, yes, this is a thrombus which is propagating within the branches of SMA. I can also appreciate that there is pneumatosis intestinalis, a bunch of bowel loops on the left side of the abdomen. They are distended with pneumatosis and with less enhancement of the wall. There is, and also somewhere in the along the right eyelid blade. I believe that this is all small bowel, and if there is misty mesentery, somewhat hazy mesentery seen. I cannot appreciate any surgical clips here. There is a calcification seen in the lower part of the abdomen. I think they could be calcified fibroid, or they don't. There's also diverticular disease in the sigmoid. So compiling all my findings, sir, in my routine practice, I would like to see the lung window to rule out any perforation as well.
Okay. So what's your diagnosis and what would you like to do with this patient?
Sir, my diagnosis is that this patient has acute superior mesenteric artery thrombosis, with which has led to some gangrene of the bowel, and there is distortion of the adjacent anatomy, I can say. I don't
Yeah,
know, maybe this is due to uh, any previous surgery, or I don't know, that there's some teething type of appearance.
all right.
And I would also like to take the history of if any previous surgery or something.
Yes,
But
there was
currently,
history
what
of
needs to
previous
be
surgery of pancreatic tumor resection. Yes. And
okay.
so,
So might be that is the reason that there is
and
hypodensity. Sir, I would like to take the review of the notes, that what was the surgery? Was it complete removal? Because there is a hypodensity adjacent to it, there might be possibility of some recurrence.
now
So,
what you will do in this particular situation, this case comes to you in duty room. The patient is in severe pain. What is
sir,
the first
urgently,
step you need to do?
there should be laparotomy, immediate laparotomy to take out the gangrenous segment and relief of the immediate thrombus, and removal of the gangrenous part of the bowel. Then second step should be restaging and comparison with the previous, what part was removed, whether it was complete or partial removal, and what should next be done, restaging or whatever, to rule out that whether there's recurrence or is it due to some fibrotic changes which has led to the thrombus. And so firstly, I would immediately convey the findings to the surgery team on call to see the to let the patient go for laparotomy.
Perfect. All right. So now I'm changing the strategy a bit. I will take case by case and will explain you so that every case you will learn something and you will improve in the next case rather than just going straight ahead to the next case. So yeah, what you did well in this case and what you can improve, both things we can discuss over here. You very well structured your the findings. You picked up the emergency finding, the urgent finding, that was perfectly spotted. The diagnosis here is absolutely correct. That is the superior mesenteric artery occlusion, secondary to some lesion, which you have already stated. So you picked up the findings nicely. You raised the concern for ischemia. You also mentioned the other ischemic findings, supportive findings. So everything was fine. And you also correlated with the previous image. These things are very important. Now, what could have been improved? That thing was you have wasted time in speaking everything. Now you got the thing. Every case has made of two things. Always remember, guys. Either there may be a safety finding or and associated another finding which may be indicating the etiology or maybe the complication. So just focus on that. Once you got it, you understand the process, why it has happened. So first you have given the observation, 2 3 points, then also pertinent negatives, that there is perforation or not, or you are concerned about it. Then you come to the interpretation. Okay, I think that there can be an ischemia, and that is because of this reason there may be chances of occlusion. And the third point would be, once you give in the interpretation, your diagnosis is there. First, you have to be safe doctor and you have to manage this patient immediately. So rather than saying laparotomy or something, you will say that as per your role, because that you are not going to decide, that clinician will be deciding. So you'll say that I will immediately pick up the phone and inform the emergency doctor and discuss with their consultant that these are the findings and this patient requires urgent surgical referral, surgical pathway referral, and urgent vascular pathway referral for the further management. That's all. That's where your job stops. Okay, you have diverted patient towards from its clinical question towards the clinical pathway. That you have to do, and that's what examiner wanted to listen. So I will give you a demo answer for this so that you would be able to understand. If I would be you, what are my findings? Okay, so yeah, I'm looking at the case, I'm scrolling it. The clinical question is severe abdominal pain. I'm looking at the findings towards severe abdominal pain. I can see that there is a portal venous gas, or uh, the branching pattern of the gas. And then I can again see that there is a pneumobilia or whatever. And then I can check that there is a occlusion of superior mesenteric artery. And I can see that there are some bowel loops which are showing decrease enhancement in the jejunal loop, also some bowel loop in the region of the ascending colon. which are also showing decrease enhancement over here in this region. Differential enhancement pattern is seen. So my finding is, my interpretation is, there is SMA occlusion and there is a ischemia of the bowel, which is emergency finding. Now I'm looking at the cause. The possible cause would be the soft tissue surrounding the superior mesenteric artery. I would like to correlate with the previous films to ascertain the etiology. There may be a previous surgery or there may be some mass lesion which is growing on. But at present, I will immediately pick up the call and inform my finding to the referring doctor to arrange the urgent surgical review for this patient as well as urgent vascular review to save the life. That's all. You're getting my point,
Yes, sir.
how the
Yes.
difference happens, yeah? So you are
Yes.
absolutely nice, but what the thing happen is you have limited amount of time, just 15 minutes. If you
Hmm.
waste more time in the case, if you speak everything, they will mark you good only, but you may be having less number of cases. So on the first case, you were very nice. You did describe everything well, but again, the management part should be pediatric orthopedic review and discussion with the consultant with a view to arrange a further MRI, something like
Sir,
that, because
sir,
you have to discuss. You,
please
sorry?
repeat again. Please repeat again.
Yeah. So it will be, the management would be. So diagnosis was absolutely right. Again, I'm repeating the diagnosis. It was the right-sided avascular necrosis, also known as Perthes disease. Every finding was correct. There was a sclerosis of the femoral head, decreased size of it, femoral epiphysis, everything was fine. All right. And you should say that there was no any gas, there is no fever in terms of clinical questions. So pertinent two negatives you have mentioned. After that, you say that I think that there must be avascular process going on. My diagnosis is avascular necrosis. In this case, this is an urgent finding. I will flag this finding and I will inform this finding to the referring consultant, especially if it comes from the GP, I will inform GP or else the referring consultant. So they will say from where the case is referred from. If it is from orthopedics, I will ask them to review with a pediatric orthopedician. Okay, so you will say
Hmm.
that I would like to manage this patient by, or I would like to arrange a pediatric orthopedic review, and
Hmm.
also would like to discuss about the further MRI to detect any opposite side processes going on or not. That's all. Only
Hmm.
two steps. You are not going to say what is the actual management or what is the surgical management. Your role
Hmm.
is from clinical question to clinical pathway. And whenever there is emergency, you need to say that, yeah, this is emergency. I will act immediately. That's all. Now you're getting what is the difference and how the UK process works, right?
Hmm. Yes, sir. Okay, sir. Hmm.
So we'll go ahead with the next case, and I want that kind of improvement in it. So this is the next case, and this is your fill.
Okay. This is.
This is, I will give you a bit of clinical history for this patient. This is
Hmm.
a kind of a newborn patient, and which is having crying and failure to thrive, something like that. Just recently born patient, 15-30 days. Please go ahead.
Okay. This is X-ray abdomen frontal projection in a 15 days old neonate patient, in which the first thing which I can appreciate is in a diffuse ear lucences scattered over the whole abdomen in a type of football shape. I can also appreciate that there is the falciform ligament is seen within this film in the right upper corner, which is not normally visualized in the patient. I can appreciate that there is air outlining bowel on both sides, and also at the region of probable protohepatic region, there is a triangular shaped free air seen. There is paucity of gases in the pelvic region of the patient, and the NG tube is seen, which means that the patient might be already in hospital. My concerns are that this is a case of pneumoperitoneum, and it urgently needs to be informed to the emergency pediatric unit on call. And I would further like to see lateral view of the patient for confirmation. So my diagnosis in this case is pneumoperitoneum It the possibilities which after I will communicate the urgent findings are that it could be any um, anorectal atresia or any Hirschsprung disease or any other cause of distalmost bowel obstruction, because what I can see that there's a paucity of gases in the pelvic region. So after the initial management is over, I would like to discuss the next management step for the patient to see what imaging patient can be having to discuss further causes.
All right. Perfect. You describe everything well. So, what could have been improved? Two things. First, whenever you start any cases which is having lines and tubes, you need to
Hmm.
comment on that, whether it is adequate or not. That is rule in UK system. So first start with, there is a tube going on, okay, and it is probably the nasogastric tube, and it is situated normally. Then you can go ahead with all your findings, whatever you have said. And if sometimes they may not give you the complete history, so you need to draw the history. If suppose this child is preterm, I am considering this as a necrotizing enterocolitis, which is an emergency finding, something like that. So you have said pneumoperitoneum, but further narrow down, which will give you good points because so there are 3 points which they are assessing. One is knowledge, which you have shown. You know the football sign, you know the things. Another thing is observation, which you missed one. You haven't spoken about the lines and tubes. The third thing is reasoning. Reasoning is that you are correlating or not, like the preterm is there, the necrotizing enterocolitis or something like that. And fourth thing is clinical effectiveness. These 4 points are made on the marking sheet of the examiners, and they have to mark for each of this domain, and then they will give you the answer. So clinical effectiveness, yes, you have raised the query, you have raised the concern, you managed the patient nicely, you were good in it. So two things: one is observation, you missed a bit. Another thing is reasoning. You need to develop a reasoning approach in UK. You can't just say that it is pneumoperitoneum. You need to think that, oh, this much young, it could be this, then this could be the diagnosis, or you are concerned for this, something like that. Okay.
Mhm.
So that is how you can improve. Otherwise, everything was fine. Perfect. Let's go ahead with the next case. So I will give you a bit of history for this case, and then we'll go ahead. So this is another child with a bit of respiratory difficulty.
Hmm. Okay. This is a chest X-ray frontal projection in a pediatric age group patient who is presented with difficulty breathing. In this, I can appreciate that there is a ill-defined haze and a small volume seen in the left hemithorax. The lung volume is relatively small. There is overexpansion of the right lung. The cardiac contour is shifted towards the left side. If both the CP angles are normally visualized, cardiac shadow is within normal range. I am trying to look actively for any soft tissue opacity or density within the left main bronchus, which is not very clear. In my routine practice, I would like to change the window of the patient, and I would also like to know that if there has been any previous episodes, or is there this is the single episode after which the child has presented with this case scenario. My concerns in this age group are that if there is an acute presentation, it could be a case of foreign body inhalation, which has been stuck. And for that, I would like to take the decubitus views in both side lower position, like left lower decubitus view and right lower decubitus view. If there has been past episodes as well, I would like to further see the previous imagings, whether this was same or not. And other possibilities which include are that it could be some mucus plugging after a recent episode of pneumonia, or it could be due to any small interrupted pulmonary artery. Pectoralis muscles are both sides are normal, so that doesn't look like the case here.
What you will
So,
do next in this case? If suppose you are having opportunity, what you are going
Hmm.
to do next? Any how you will manage this patient now?
There is, I would like to take the history. That first of all, that is it the acute at first presentation, and
No,
after
it's
that, I
not
will.
acute. It is since long. Recurrent breathlessness happens and not sudden acute.
Sir,
Then
I
what
would
you will
like to see CT chest of the
all right.
patient.
I will give you CT scan for this patient. Please go ahead. Please take a control and scroll it and let me know what are your findings.
Okay, sir, I would like to take from the start. So it is starting from
Yeah,
here.
it's the yeah, yeah. This is the starting point. You can start with that.
Okay, so these are CT chest lung window images in the of the same patient, in which I can appreciate that there is left upper lobe collapse, and there are multiple ill-defined patches of consolidation, ground glass opacity seen in bilateral basal regions. They are more towards the periphery of the lung, and there are some prominent there's some bronchiectatic changes as well located
Mhm.
in the parahilar region. I can also appreciate that in both lung parenchymas there are multiple tree bud opacities seen. Um, Sir, can I see the coronal window of the patient?
There is no availability of corneal window, but you are on right track that I can tell you. And now you have to just join the dots, like recurrent infection and bronchial dilatation in a child, and there is some collapse. What it makes it, and how you will manage
Uh,
this patient.
Sir, my concerns are that it could be tuberculosis. And secondly, I'm thinking of any mucus plugging secondary to
Hmm.
any chronic asthma, uh, resulting in allergic
Any genetic
bronchopulmonary
condition
asthma.
which causes mucus plugging?
Cystic fibrosis is the
Okay.
it can be an early presentation of cystic fibrosis in which there is not a gross dilatation of bronchi. So in this case scenario, I would like to further advise IgE levels, the level of eosinophilic count in the blood, and I would like to advise a test for cystic fibrosis for patient as well as sputum for AFP to rule out
All right.
all the three causes. Number one, my differential is cystic fibrosis. Second, possibility that it could be allergic bronchopulmonary aspergillosis, which is complicated the asthma. Thirdly, it could be tuberculosis because from the background where I've come from, we would strictly label it as tuberculosis. So these three, and next the further three tests can are going to differentiate between the causes.
Okay. All right. So you did very well on this case. Only thing which I would like to tell you is, you could have picked up the upper lobe collapse left-sided, that Luft seashell sign on the
Mm,
first attempt over here. If you could see that, there is a lucency surrounding it. So if
mm,
it could have been picked up, it would be the great, but it's fine. So basically, if you are able to pick it up, it's fine. But if you are not, then you should know how to manage that patient. So examiner won't give you the next investigation directly. You need to draw it from the examiner. Like, I hinted you and you draw the CT. The problem with this exam is more the hints, your marks will be deducted. So there is an
mm,
option. They will, mention that the candidate was able to pick up with some amount of help. If you read the scoring, then your score will be decreased. So try to
mm,
get it. There are few cases. 2B exam is the kind of the picturesque version of 2A exam only. So whatever the topics were there in 2A exam, that will be converted into pictures in 2B exam, nothing else. So there are few particular scenarios are there. Whenever you see this kind of, recurrent infection and collapse, always think like that, your way was excellent, but you could have done it very fast as well if you know about this case. These are the standard cases which are coming in most of the exams. So just try to understand this scenario. Otherwise, everything was fine, and you could have just said that I will refer this patient to the pediatric chest physician and as you said, that to ascertain the three causes, like what you have said, and they will do the rest, something like that.
Mm.
You are not supposed to tell like what immunoglobulins and something. It will be too much lengthy. You just direct to that path. That's all.
Mhm.
Okay. Otherwise, everything was good. So next case, last case for you, I think, because we are running out of time. I will give you this case here. This, if you could take, please, and I will give you the history for that.
Okay. Uh,
Yeah, just a second. So there is a head trauma in 45-year-old male, and after head trauma, there is headache, severe headache.
hmm.
Please take control and go ahead.
Okay. This is a CT head axial section in a patient, particularly based in the base of it is partially not completely seen the brain and axial plane. Is it only this? They have
If
given
you
it.
could go ahead, then it will be fine. Yeah.
It
Yeah.
is going down. Sorry. I will just take a moment to scroll in this plain CT brain axial section. In this, I can appreciate that there is a subgaleal hematoma in the vertex region of the skull, and there is some effacement of sulci gyri in the right right parieto-temporal region. Um there in my first scroll, I was not able to pick anything, to be honest. So I will try to go for my review area, starting from the base of the skull. I will try to look slice by slice to rule out any possible. What have I done?
Yep. Sorry, I think something is going on. Just a second. Now it's
Sir,
fine?
it's fine, sir. I'm requesting for control once
Yeah,
again.
please. Yes, please. Now you have control. Please take.
Okay, sir. Yes. Um, so I'm trying to look for any associated findings in this patient. All I could appreciate is a small hematoma in the vertex region. So can I go for a bone window? Because in this current study, I was not able to find any significant midline shift, any contusion. I'm also trying to look for any subdural hematoma or any isodens hematoma collection, which is not there. There is no uncal herniation, and the bones apparently look normal, but I would like to see them on the bone window.
Okay, I will give you bone pillow. Please go ahead with bone pillow.
Okay. Mm, these are the, I'm going lower down, just let no. It's okay. So there is mastoiditis on the right side. In the base of the skull, I cannot appreciate any fracture through the petrous bones. There is mm,
Do you know any causes of severe headache after trauma or anything like that? What are the causes?
the severe headache is can be related to vascular causes. Um, like there could be any bleed, any already going on aneurysm rupture, or it could be due to it could be due to edema. A significant brain edema can also lead to but in this I'm not able to appreciate anything. I would like to look for any fullness in the region of orbital region, which is not seen. There is no evidence of any fracture. Sir, is
What
there
are the
any other
vascular review
studies?
areas? What are the vessels, various kind of the vessels, and you used to look at whenever you are assessing headache? One you
Um,
said arteries. What are the others?
Veins. I should look for veins as well. Um Sir, this area, they are not symmetrical. This this region, I can go for the
Yeah, you
soft
can
tissue,
take whatever, which you want. Axials, soft.
yes,
Yeah.
axial windows again, because I appreciate that there is some um, asymmetry seen in the bones in that region of right occipital bone.
Hmm.
And there was some hyperdensity in the right mastoids as well. And I'm concerned for some heterogeneity in the heterogeneous foci, hyperdense or hypodense in this region. It could be due to any sinus thrombosis post trauma in this region. There is a small air focus as well, this here.
That was the
And
finding. Okay, now you got it. I'm sorry, I'm stopping it because the time is less. So
so
chances
CT.
of sweet, this was the pickup finding. Okay.
Mm-mm.
If you go here, this was the pickup finding. So if I would be you, how I will approach this case? Whenever I come to know about headache, my clinical question is headache post-trauma. I will scroll the scan. So, okay, my clinical question is headache. I'm looking at the scan once and then I will come back with my findings. Then I used to look at the case. I will look at the first subarachnoid hemorrhage areas. And I don't see any hyperdensity along the cisterns or any traumatic site. Then I'm looking for any vessel damage. I don't see anything, no any intracranial hemorrhage as well. Now I'm looking for the venous sinuses because the cavernous sinus or any dural venous sinus thrombosis could be the cause of headache. So I'm looking at the symmetrical areas of the venous sinuses, but here I can see that there is something problematic. There is air foci within the sigmoid sinus, and I would like to raise this concern, and this is not confirmed, but I would like to raise this concern, and I would like to arrange the CT venogram, contrast CT venogram for this patient. So once you say
Mm.
that, they will give you the contrast CT venogram. And once you get the venogram, then you can see that, see, there is nothing over here as compared to this, but
Mm.
here there is contrast. So that's the finding, and this is how you can approach. And then you can say that this is a safety finding, immediate concern. I will raise the issue to the referring clinician and requires urgent stroke team referral or review or urgent vascular team review, something like that. But yeah,
Mm.
it was a bit tough case, but you need to kind of develop this kind of easy case, but rare areas, how to assess them. So that would be my
Mm.
next teaching point from this case. There will be easy cases, there will be safety finding cases only, and you need to develop your review areas for that easy finding case because once you miss safety finding, they will simply write that you are unsafe radiologist and you are gone. That's the problem with this exam. However good you are at other cases, this kind of the small mistakes sometimes may make you unsafe radiologist. And some examiners may directly write that. So that's the problem. So I hope you are getting everything, and I hope this session is nice for you. If we are getting more time, I will go with the further cases. But as of now, we'll go with the candidate two. But candidate one, your preparation is good. You are doing really well. Only three things I would like to tell you: focus on less, management things, like just
Mm.
try to divert the patient, try to focus on the causes, the common scenarios which you understood during your 2A exams. Just try to remember that scenarios two or three top differentials and you just look at that areas only. First, make your case in your mind and then look for the review areas. Most of the times, the safety cases are like that only, and that will make you or break you. If you got all the safety cases right, I think your exam will be cleared.
Mm.
But if you got one wrong, then there will be a problem. So don't miss on safety cases. That's the only thing which I would like to
Yeah.
tell you.
Mm.
All
Okay,
right?
thank you so much for your points. Thank
Otherwise,
you.
everything was good. Yeah. So, next candidate, I'll just not sharing my screen and will load your
Hello.
cases. Just a second.
Hi.
Yeah, 1 minute, please. Are you ready, candidate two?
Yes, sir.
You are not audible clearly. You need to raise your voice a bit.
Uh, my voice clear?
Yeah, now it is clear. Perfect. So, candidate two, this is your case number one, and I will give you a bit of history. The patient is having dysmenorrhea, and you have to ask me control, and you can scroll it. You know how to ask control?
Yes, sir. I am requesting
Yeah,
for
perfect.
controls.
Yeah, you can use up and down arrows, and as I have explained to candidate one, you can assess this case.
Okay, these are grayscale transvaginal ultrasound images of a patient having a history of dysmenorrhea. I can appreciate the uterus. It is anteverted. There is um, I'm looking at the junctional zone. Um, there are small irregularities at the anterior aspects of the junctional zone. The loss of hypoechoic line of the junctional zone, and also on the color Doppler image, there are increased vascularity along the anterior myometrium. Um, I would the both adnexa in these images are not provided. In summary, in this patient, there is appreciation of loss of junctional zone along the anterior uh, aspects with the heterogeneities along the anterior myometrium showing increased vascularity. So my principal diagnosis in this case is adenomyosis with a focus of adenomyoma. Other differentials in this case would be developing fibroid along the anterior myometrium. So I will inform the findings to the referring gynecologist and suggest referral to the gynecology team. Also, would suggest MRI of the pelvis for further confirmation of my findings. Thank you.
All right. Yeah, perfect. All the things picked up, but there are some things which you can improve. That is in the knowledge part. Knowledge to hear that there is asymmetry in the myometrium. Have you spoken that? I don't know whether I missed it or not. Because you see
Heterogeneity is
the
along
anterior.
anterior myometrium.
Sorry.
I said heterogeneity is along anterior myometrium.
No, asymmetry, I mean the size, the thickness, the asymmetry. The anterior wall is enlarged as that of the posterior wall. Otherwise, heterogeneity, you have spoken that I know. Otherwise, everything was fine. So, and you managed it nicely. You sent it to the gynecology team. You also discussed regarding MRI. So, yeah, you picked up very well. You managed all the tick boxes nicely. Perfect. Next case. So I will give you history for this case and then you can go ahead. So this is a 50-year-old male with abdominal pain, nausea, and vomiting. You can take a control, scroll it, and just go ahead.
Sorry, I have given up control. I have requested.
You
I have
need to
requested again.
re-request it.
I have
Yes,
requested.
no
Yeah.
problem.
Yeah, so these are axial sections, contrast enhanced CT abdomen, and oral contrast is also given because I can see the oral contrast in the stomach. Uh, in the lung bases, I can appreciate that there is a nodule in the right lung base. I'm looking down. There is also, yeah, yeah. I'm scrolling down in the left side of the abdomen, in the region of the jejunal loops. There is invagination of one bowel loop into the other, favoring intussusception. I am looking for any lead point causing this intussusception. And there are small mesentery with small lymph nodes going into this in the recipient with a heterogeneously enhancing area invaginating into the bowel loop. The visualized liver shows no focal lesion. The spleen is also unremarkable, as is the pancreas. I'm going down. Both kidneys are excreting the contrast normally. There is sludge in the gallbladder. Yeah, going down. Also, there is marginal thickening of the bowel. Uh, Incidental note was of a small cyst in the right kidney. In the pelvis, yeah, I could not see any gross abnormality. Um, so, uh, in summary, in this patient, there is a presence of invagination of one loop of the bowel with the other. Um, showing with a small nodule in the right lung base. In my routine practice, also there are multiple deposits in bilateral lung fluid. This likely suggest metastasis. In my routine practice, I will go through the lung window and also like to see on the coronal images to further confirm my findings. However, confining to this case, as there is intussusception in the left side of the abdomen, likely jejunal with the thickening of the bowel and invagination of the mesentery showing lymph nodes. So the cause could be lymphoma causing intussusception with the lung metastasis. There was a small non-enhancement of the bowel wall I was suspecting, so there could be some element of gangrene. Yeah, as this is emergency, first I will pick up my phone and inform the referring physician about the finding. Will suggest referral to the surgical team, and further I will suggest referral to the gastro-onco MDT. Also suggest staging CT and PET CT in this case. Also like to see the bone window available in this case.
Okay,
Thank you.
all right. Nicely picked up the main finding. That was fine. Managed it nicely as well. Now you check that you can't see the enhancement properly, like as that of arterial portal phase, because it is kind of delayed phase, where the excretion has already started. So less likely you would be able to comment on that. Now, what are the causes where, adult intussusception happens with pulmonary metastasis, and where you need to look next? These are the common scenarios. Have you read that kind of questions in 2A? So do you have anything in mind? I will give you one chance if you could pick up.
Sir,
Adult
these could
intussusception.
to that due to bowel lymphoma, as also
Another?
other differentials would include adenocarcinoma of the bowel with the lung metastasis,
Any dermal
and
malignancy,
Never syndrome.
No, it's a malignant melanoma. Okay, which is very common in UK as well, and which is leading to this kind of metastasis and intussusception. If you could check that over here, there was a lesion, though it was not dermal, but this lesion, if you could have picked it up, it would have been better. Are you able to see this lesion over here? Uh, are you able to follow my arrow behind the iliac bone, right iliac bone?
Yeah, this
This,
one.
yes.
Okay.
Yes. Okay, so that was another lesion which I wanted you to take it up, and I wanted you to also correlate it with the malignant melanoma. Don't worry, this is kind of, because we are not accustomed to this system, that's why it is difficult to pick it up first. Otherwise, UK candidates, they are trained in such a way that they will pick up this diagnosis first. So that's why I have put this case up. And this is very important case, mind that. Otherwise, everything was fine. You raised the concern, you said the management, and you also said the staging scan is required. You also said the bone window, etc. was fine. But just this thing, this particular scenario, just keep in your mind. Okay. And then next
Mhm.
case. I will give you the history for this case and you can go ahead. It's a 12-year-old child, and just a screening radiograph for some other purposes. Are you able to detect something on it? We'll give you a bit of zoom in.
Please refrain. Can I ask candidates to refrain from writing? Because, okay, this is frontal, this is just radiograph frontal projection of pediatric age group patient. I, at my first glance, I could not make any lung pathology. There was no pneumothorax or pneumomediastinum. Both costophrenic angles were clear. They visualized bone, although the spine was not clearly seen. They visualized, yeah, I could see that there is inferior rib notching, bilateral inferior rib notching in the upper ribs. This one, and this also on the left side. I can see inferior rib notching.
Mhm.
These could be, and also I cannot see the aorta. The heart was also somewhat enlarged. Um, so this could be due to coarctation of the aorta. But yeah, in this, I will also like to see the bones on the right side. I think there is some lucency lytic lesion involving the rib on the right side. One, two, three, four. Um, there is also bulky right hilum. So in my routine practice, I will further like to see the history and also will like to see the comparison with the previous imaging if available. Um,
This is a
and
screening. First time just came out of the screening, and the findings are there. So now what you will do next?
I will do cross-sectional imaging in the form of CT chest.
Mhm.
And
Is it required
also,
at the moment?
at first, if I could not see any finding, I will take help from my senior colleagues. Um,
I think okay. All right. So yeah, you picked up correct. Inferior rib notching. You have to say that aortic knuckle is not seen, and it was coarctation, but then you missed your way. So this kind of the cases will be asked where there is only one finding, and they want to check that whether you are still safe or not, you are still confident or not. If I would be, I could have said that, in this screening film, I can see that there are some inferior rib notchings. I can't see aortic knuckle very nicely. So I think that this patient could be having coarctation of aorta. That could be my first differential. Meanwhile, there are other causes of rib notching, which I need to ascertain, like hypothyroidism, all that things. And I will just have a look at clinical profile to rule out all the other causes. And if they are not, then I will refer this patient to the cardiovascular physician or the vascular surgeon, and to decide the further workup in this patient. So you just have to transfer from one pathway to another pathway. They will decide what to do, cross sectional, not this, that. Your job is this much. Okay, so this was very straightforward question, but most of the candidates does like this. Once they pick up the finding, then they will feel like, during the exam there is stress, obviously, that there must be something else, I'm missing something. Don't worry, they will ask you only 2A type of the cases, but in the picture manner. Just mind that, just remember that scenarios only. Okay, otherwise you will do blunder. They will mention that this radiologist is not safe, is speaking too much, saying a lot of things, your marks will be deducted. So just be sure. And in this kind of small cases, short cases, they will be having some additional questions. So they may ask you, what are the causes of rib notching? So in small cases, you have to read and remember some additional stuff as well. Okay, some causes or some how the rib notching happens. They may ask you a bit of the pathophysiology that was asked in many exams. So that's how this kind of the cases are dealt with. Okay. You getting my point? See, everyone, it's like everyone will teach you cases, but it's not about cases. What I'm trying to tell you is you develop that approach because, in UK, the thing is they are expecting us to become a robot. What they are thinking is, in human mind is very nice. They can do wonders, but when it is fatigue, there may be chances of error. So they don't want to take any risk for their patient. So they are trying to make their trainee or doctors like that whatever the strategical things are there, this kind of the features, you have to speak this thing up and you have to refer to this person. So then and then workup will gonna go ahead. So it is like a chain which you have to follow. You need to make yourself a robot in particular situation, that I will look at this finding. If screening type of film comes, there are 4 or 5 things which, it can be coarctation, it can be something else, like, maybe any some nodules might be there in screening kind of film, can be mastectomy, would be there, some clavicular pathology could be there. So there are fixed things for each and every type of the films. You just remember that, just have that checklist in your mind, and just look at them first and then think about all the other things. That would be the best approach for your exam and for the UK system where they need robots. Okay, now
Okay.
next is for you, and I will give you the clinical features for that. It's a 45 years old male, and there are occipital headaches for this patient. Okay, and vomiting as well as dizziness. If you could take a control and scroll it.
Okay, this is a CT head, axial sections, a brain window, 40-year-old patient having vertigo and headache. Um, I can appreciate that there is a well-defined cystic lesion, well capsulated in the posterior cranial fossa involving the right cerebellum. It is causing mass effect on the midline vermis, and also there is marked compression of the fourth ventricle uh, with resultant mild hydrocephalus. Uh, they, yeah, in the superior supratentorial location, and uh, there is no evidence of any hemorrhage or ischemia. There are hyperdensities in the superior sagittal sinus right over here. However, um, the so in summary, in this 40-year-old patient, a well-defined cystic lesion in the posterior cranial fossa in the region of the right cerebellar hemisphere with the marked compression of the ventricular system. uh, my principal diagnosis in this case is likely a abscess, brain abscess. Uh, uh, so with developing hydrocephalus, as this is emergency, I will pick up my phone and inform the referring physician. Will suggest a referral to the a neurosurgical team for urgent management, that would be in the form of ventriculoperitoneal shunting. Further, I will suggest contrast enhanced CT or MRI in this case to further see the wall enhancement in the
I'll give you
CT.
MRI. I will give you MRI. You requested me MRI. We have MRI. I'll just give you MRI. Okay, this is the sequence for you.
Okay, this is sorry, this is. axial T2 weighted image of the same patient, further showing hyperintense cystic lesion in the right cerebellar hemisphere, causing compression and mass effect on the midline vermis and also the fourth ventricle. Uh, mm, um, um, I am looking at the dural venous sinuses. These these look fine. So I will like to see the on the contrast enhanced imaging for further evaluation, also the figurative imaging if available. Other differentials in this case would be some pilocytic astrocytoma. Can you go to the contrast enhanced
The
imaging?
patient is adult. The patient is adult, 45 years age. What are the differentials, please? Directly, let's go to the differentials and management directly.
Okay, okay, this could be some cystic neoplastic lesions, likely hemangioblastomas or pilocytic astrocytoma. Other differentials include cystic metastasis, as this is intraaxial lesion. So, if this would be extraaxial, then my other differential would be arachnoid or epidermoid cyst. Um, uh, so, can I
How
have
you will manage?
so I will inform the findings to the referring physician and will suggest referral to the neurosurgical team for further management. Also, as this is emergency, I already said that there is marked compression of the fourth ventricle. So when there is urgent need of ventriculoperitoneal shunting. Also, whole of the yeah.
All right, no problem. So you were right, no problem, but there is some UK way of doing this. I will tell you that. So what they are doing is, okay, I can see that there is a CSF density lesion, which appears to be cystic, and I'm looking for any internal soft tissues within it. So I can see that there is a hyperdense soft tissue within it, which this is the contrast and it is enhancing. So then yeah, I can see that it is blocking the fourth ventricle. So there may be chances of hydrocephalus, which is developing at the moment, bit of the prominence of the temporal horns are there, which supports my diagnosis. Now, in this case, I'm suspecting with the age, the first differential would be cerebellar hemangioblastoma because there is a hyperdense enhancing vascular
I
nodule,
was not
and
provided contrast entry. Yeah, sorry, I was not
yeah, so
provided
you need to
contrast.
say that, whenever you are saying, if do you have any contrast city images, please? Something like that you need to say. So that's where I'm taking you. I'm taking you all that things which you need to do during exam, by showing you cases, by making you commit the mistake so that in real exam you will not commit that. Okay, so whenever you are seeing that, you can ask, I would like to check any contrast scans images available or not. So if they are having, they will give it. They say that no, no contrast images. Then you can say that, oh, whenever you are coming to that kind of case, you need to speak differentials, as you said. My top three differentials, as per the clinical question, could be cerebellar hemangioblastoma, or could be this or that. Never commit on abscess very fast unless there is a fever, unless there is acute presentation, something like that. If the examiner speaks that, then and then you should commit that. Otherwise, you can say that, oh, yeah, that can be included in differential, but I would like to assess with the contrast image on the CT or else MRI image. Whatever you will speak, they will give you that. If you have spoken contrast CT, I could have given you that. If you spoken MRI, that's why I've given you that. So now the UK way, another way is whenever you are suspecting hemangioblastoma, VHL is kind of peculiar for the Royal College. So you need to speak that this patient could be having a von Hippel-Lindau. So I may ask for the any family history in the patient for the similar diseases. I would like to refer this patient for the multiple workup and MDT discussion. This kind of the patient, you need to speak this word. You need to send this patient to the MDT pathway because this is like a complex disease which involves multiple person to discuss. You raise the hydrocephalus, that's fine, the urgent, but afterwards everything will be decided by the MDT. In UK, what happens is single person won't take responsibility because if something goes wrong, that will be a problem to him. So everyone will get together, will sit in a room, will decide what to do for this. Like the surgeon will look at the, any possibility of resection. Another person will, oncologist will look at possibility of VHL. They may plan further MRI spine, further thorax, abdomen, pelvis CT for the neoplastic staging or something like that, detection of another tumors associated with it. Genetic people will say will do the genetic counseling and testing, something like that. So you have to say that you will refer this patient to MDT. So may lose mark on the safety finding because you have it would be classified as a scattergun approach in this. They will mention in your mark sheet as a scattergun approach that you have spoken up any finding, you have spoken up anything which doesn't make any sense in this particular clinical scenario, and you will lose mark. And you haven't directed the patient towards MDT. Again, you will lose mark. Even though you know everything, but as per UK guidelines, as per their competency, you may lose mark. So that's what this case will is teaching you. So my purpose for today's cases are, you do mistakes, you understand what the UK people requires. And that's what we are, kind of focusing on. The last case for you, if you pick it up early, just pick up the diagnosis and management, then I can show you two cases which are important for everyone.
This is a frontal radiograph of the hand of pediatric age group. I can appreciate that there is juxta-articular osteoporosis involving the metacarpopharyngeal joints and also carpometacarpal joints. There is no evidence of any fracture in this case or any lytic lesion. Likely this is a case of juvenile idiopathic arthritis. Other differential in this case would be rheumatoid arthritis, um, or other
I'm
differentials include.
just stopping you. Are you able to see this angulation?
Okay. There is some lucent line involving the uh, proximal metaphysis of the proximal phalanx. Um, and also I think there is also soft tissue swelling surrounding soft tissue swelling. So I would like to take the history of the patient, whether there is history of trauma. uh, uh, if there is any history of trauma, then this could be due to Salter Harris fracture type 2, or if there is any history of infection, then it would be due to some
Okay,
osteomyelitis.
so Salter Harris type 2, how you will manage this patient?
So I will inform the finding to the referring physician, will suggest referral to the pediatric orthopedic team, immobilization of this
All right.
finger, and also repeat follow-up imaging.
All right. No, perfect. You got it right, but you didn't pick it up earlier after hinting you, after, completely saying you that. Otherwise, you should pick it up. Whenever you get pediatric hand, always first look for fracture. So what I'm advising you is, or even we are going to discuss in our further classes, what could be the sequence of abnormalities you need to see in a particular image, in a particular scenario. You need to remember that thing. I will also, in the end, I will also say you by which book you can do that, by following which book you can kind of remember that as well. So no problem in that. But for every imaging, you should have certain differential skip in your mind. You won't be able to remember it. So what you have to do is, if you have 3 to 6 months in your hand, just every day do it so that it will be in your automatism. It will be in your spinal level. Try to practice that so that you don't have to put any effort while doing exam. It just comes out like a automatism, like a robot. So that's what I can tell you. Every film has a particular 5 or 6 diagnoses in particular scenario. Just remember that, you will be fine. This patient, you just need to pick up the finding and tell me what do you think very fast. Okay, 90 years age and diabetic patient with acute abdominal pain.
Okay, this is frontal radiograph of abdomen. There is gas within the wall of the bladder, uh, uh, and also there is gas fluid level. Um, so likely this is a case of emphysematous cystitis. as the patient, the history is also suggestive. So as this is emergency, I will pick up my phone and will inform the referring physician, will suggest referral to the urologist for further management. In the rest of the imaging, I can see that there is calcification, calcified spot on
All right.
along the
Okay.
right
No,
ventricle.
you did well. You did well. Perfect. I'm sorry I'm going a bit fast because, I have to show you all these important cases. Last cases for you. Last case for you. If you could just take a scroll and just give me diagnosis and management for this one. This is also a very important case.
Okay, sorry. Yeah, there is a cystic lesion in the posterior to the urinary bladder. I am looking its connection with the uterus. It shows it is appearing hyper intense on this T2 weighted imaging. There are seems to be two uterine cavities. So likely this is a case of hematocolpos in one of the horn of the in the uterus didelphys. I would also like to see on the T1 weighted imaging and also on the axial imaging. Also like to take the history
I'll
of
give
the.
you T1 weighted image. Yeah, just a second. This is your T1 image. So what's your final diagnosis and how you will manage this patient?
Okay, in this T2, T1 weighted axial image, again, I can appreciate that the cystic lesion, this is communicating with the vagina, and also there is evidence of this is communicating with the uterus. So likely this is a case of hydrocolpus. Um, so I will inform the finding to the referring physician, will suggest referral to the gynecology team for further management in this case. Um,
Okay. So if I would be you, I could have spoken like this. The I would first ask whether the patient is having a, I would ask to the examiner whether the patient is having a normal menstruation or not. The examiner will say that, yeah, she's having normal menstruation. Then now I can focus on that. That, yeah, okay, there are two canals, two endometrial canals, two cervical canals, and maybe opening in vagina. So, but one of the side of the cervicovaginal canal is completely obliterated, and which is showing shedding sign on T2 image. So it could be a hematocolpos. But on the other side, I can see that it is normal. So there are two cavities. So it could be uterine didelphys uterus with two cervix and two vagina. And another thing is, what I will look at is any other abnormalities like vertebral anomalies or something related to the other associations and kidneys as well, if it is uh, seen. And I will refer this patient to the gynecology team. That's all. So you need to speak up this word, didelphys uterus and bicollis or unicollis. Whenever it is unicollis, then you have to say unicollis, bicollis, then you have to say bicollis. This would be the mark getting point. They want to know this knowledge from you, whether you know the differences between the unicollis and bicollis, didelphys, bicornuate, septate, all that things. All right. So you need to give that answer. I hope this uh, is beneficial for you, and we can go ahead with the candidate number 3
Thank you, sir.
afterwards. Yeah.
Excuse me, Dr. Mehta.
Yeah.
Candidate 3 hasn't joined in yet. So would you please start with candidate 4? And after candidate 4, if candidate 3 hasn't joined in yet, there is a volunteer who's happy to take his place. So hope
Okay.
this will be
All
fine.
right.
Okay.
Yeah.
Thank you.
Just give me a moment. I'll change the playlist and come back. I'm just stopping the screen share. I'm sharing my screen, and candidate 4 is ready.
Yes, doc, I'm ready.
Yeah. Are you able to see my screen?
Yes.
Perfect. So this is first case for you, and this is 55-year-old male patient presented to the emergency department with non-specific abdominal pain. How you will manage this patient?
Okay. I've been provided with frontal radiograph of mature skeletally patient. I will have a look for the chest X-ray. This patient is coming with abdominal pain, non-specific. Just I will have a look as I couldn't see something clear in the X-ray. I will go for check the parenchyma. I can see that both parenchyma and both hilar appearing normal. I will go for the reviews area. Both lung apex appearing normal, both costophrenic angle and also retrocardiac appearing normal. Mediastinal and trachea is detecting within the midline. I will have a look for the bone. I couldn't see abnormality noted within the bone. Maybe I can see that there is some evidence of reticulations with bronchiectic, fine bronchiectic changes noted within the left upper lung parenchyma. But I couldn't see any other finding rather than this. I want to look for the soft tissue within the abdomen as the patient is coming with abdominal pain.
Okay. Anything in chest X-ray? Any other thing are you able to see?
No, for this, I will look for the soft tissue also. In the chest, I couldn't see abnormality within the soft tissue. So I really couldn't appreciate marked abnormality within. Maybe there is here in the left lung something, but I am not sure about it really.
Okay. Would you like to look at the right lung field very carefully, especially the peripheral areas?
Yes, in the peripheral, I can see that there is bilateral. There is two well-defined pleural-based nodules related to the lateral aspect of the pleura. I couldn't see that there is evidence of fracture ribs noted or destruction of the ribs related to it. So in this case, I want to check the CT for this patient to see
Okay.
if there is.
I'll give you CT.
Okay, this is
Please
the
go.
scanogram. Okay.
You can take it, cut the control, and you can
Okay.
scroll it from here. You can request me control here.
Okay.
Yes, please.
It's not. Just 1 second. It's not scrolling.
You need to go with the arrows, up and down arrows,
Okay.
not the right and left arrows.
Yes, I'm
Can I
using the
scroll it for
arrow.
you?
Okay. Okay.
Perfect.
It started.
You are doing.
Started.
You are doing. Yes.
Okay. This is the axial CT for mediastinal window for the same patient. It's with I can see the lesion that I noted within the X-ray. It's a pleural-based lesion with hypodensity, soft with hypodense. In my routine practice, I will check this Hounsfield unit. Maybe it's fat content. It's just I will go more to check if there is any other lesions. Okay. Okay, it's only for the chest and the upper abdomen. I couldn't see something in the upper abdomen. So I will go back to this lesion. It's only this well-defined hypodense lesion with fat content. I believe it's fat content because it's low density, and I couldn't see
What's your
that there is a,
diagnosis?
okay, it could be a pleural lipoma. Also, it could be pleural fibroma with no, sorry,
How
it's
we will
lipoma.
manage this?
I will convey my finding for the chest team for discussion for this and follow up maybe if it's approved to be according to their appropriate management plan.
Okay. All right. So few things. First of all, you just missed that thing. So whenever this kind of thing comes up, like non-specific thing, just keep in your mind. You first have to speak as per the clinical question. So there is an abdominal pain. There is erect chest X-ray. First finding you should look at is always pneumoperitoneum. Okay, or air under diaphragm, because the main concern is abdomen. We are not here to detect diagnosis. We are here to manage a patient. So whenever that comes, you should say that there is no pneumoperitoneum or no air under diaphragm. That should be your first wording. After that, you should look at the film. If you are not able to see anything, you should say that I can't see anything over here. Uh, I would like to look at my review areas, but I can see that there is a pleural based density or opacity along the right pleural margin. So I don't see anything related to the abdomen. I can't see any radio density in the gallbladder region, and stomach gas shadow is also fine. So rest findings related to the clinical concern, I'm not able to see, but I can definitely see that there is a mass-like lesion, pleural-based opacity. So in that particular case, I would like to inform this finding to the referring clinician. I would like to tell them that this patient deserve CT scan thorax plus abdomen to assess the abdominal causes as well as the thoracic lesion as well, so that we can assess this patient further on. Something like that you need to say so that it will allow you to manage the patient in terms of the clinical question. You direct it towards that pathway, and you also raise the concern and you guided the next intervention or next scan. After that, once you have CT scan, you looked at the scan, you need to say that, okay, I can see that there is a pleural base fat, everything was fine. In the end, you need to say that I will refer this patient to the MDT uh, with a note saying that there is no definitive internal aggressive potential, no any rib erosion, that findings, that pertinent negatives you need to say. Don't know any other similar lesion. So it may be a low grade or benign lesion, but I do recommend MDT referral to decide what to do with this lesion further on, whether to biopsy or whether not to biopsy, something like that. So you are referring this patient to the MDT and they will decide what to do next. But you have said all the pertinent negatives, that it is not aggressive, that you need to say. And further on, I can't see anything in abdomen, but I need the full scan to assess whether any cause related to the uh, uh, clinical features are there or it's just a non-specific dyspeptic episode. That's all. You getting my point? How to say, how to
Yes,
manage this patient?
yes, yes,
Any
doctor.
questions for this?
No, no.
So keep in mind, whenever you see something mass lesion, something complex thing, divert it to the MDT. Okay.
Okay,
So you have to
okay,
say such sentence, I will inform or I will write a note to the referring clinician that this patient should go into the lung lesion MDT, something like that. So you are also telling clinician to send this patient to the MDT. Okay?
okay.
Something like. Now, next film for you. And the clinical features for this is 17 years old male, 17, with sudden onset of abdominal pain. If you could please take this case for me.
Okay, this is a frontal radiograph of mature skeletally patient coming with sudden abdominal pain or acute abdominal pain.
I'll
Um,
give you both the films. I'm just sorry.
okay.
Yeah, go ahead.
Okay. In this, the first X-ray, I can see that there is no evidence of there is evidence of multiple small bowel dilated, noted within the the left upper quadrant of the abdomen. However, the lung appearing normal. There is tiny multiple small nodules noted within the lung. Just I will go back to it, but because the patient is coming with severe abdominal pain, I will go for the next X-ray. In the next X-ray for the frontal abdominal radiograph, I can see again that there is evidence of multiple bowel loops, which appear to be large bowel dilatation, as I can see that there is evidence of hostrations detected within the right upper quadrant abdomen. For me, it's giving the appearance of embryocene, which could be cecal volvulus, as I couldn't see also that there is any evidence of gas noted within the right side of the abdomen. And also I couldn't see that there is evidence of descending bowel gas, descending loop, descending colon.
What do you think
So
what it could be and what you will do next?
I think it could be cecal volvulus. And I will arrange for CT for this patient for confirmation of the diagnosis.
Okay, let's check the CT and you can tell me what are your findings. Just a second.
Okay.
Please take the control and scroll it.
Okay. Should I ask the control again, or are you ready?
No, it's fine. I think it's in your
Okay.
hand.
Okay. This is axial cut CT abdomen portovenous phase for the same patient for lower chest and the abdomen. While I will scroll and then I will comment. Okay. While I am scrolling down, just okay. While I am scrolling, I will go back to the interest area as it is the main concern for me, this region. I couldn't see the ascending colon in its normal position, and there is evidence here of dilated colon. Mostly this is a cecal mostly this is a cecal part of the ascending colon. Just I want to look for a spiral sign for the vessels and the mesentery. I want to okay. This is the intestine, and all the small bowel appear collapsed, and also the rest of the large bowel appear collapsed. Only this the region that appear to be dilated. Okay.
Okay, so what's your diagnosis and how you will manage this patient now?
Mostly this is a cecal volvulus, and I couldn't see that there is any evidence of pneumatosis intestinalis or pneumoperitoneum. However, I would check in the lung window. So I will convey my finding urgently for the GIT surgical team for discussion and appropriate management.
All right, perfect. This case you did really well. I don't think so there is any problem. So next case we are going towards.
Okay.
And yeah, you can take it. This patient is having back pain.
Okay.
And it was gradually increasing.
Gradually increasing. Okay.
Over 2 months.
Okay. Okay.
The patient age is around 50 years. You can scroll it and let me know what do you think about this.
Okay. I've been provided with sagittal cuts T2 for lumbar spine for the lumbosacral spine for patient coming with severe abdominal, with severe with back pain, which increasing gradually. The most important thing that I can see that there is evidence of Just 1 second. This is 5, 4, 3, and 2. There is evidence of L2, L3, and L3, L4 disc herniation. However, I want to look for it in the axial cuts. Because I have concern that in this region that there is evidence of external neural exit foraminal narrowing and compression of the nerve roots, which may be cause for coda equina syndrome when it's go more progressed in its
Can give you
compression.
axial cuts then. Yeah,
Okay.
I have few axial cuts, so I can give you that. I'm
Okay.
sorry. Yeah,
Okay.
you can just take the axial cuts. I'm sorry if we don't have that synchronization, but you
Yes,
just have
yes,
a look at
no
the
problem.
coda
I will just,
equinus.
okay. It's from down to upward. Here, I think the level, just 1 second. This is mostly the level, these two. Here I
Okay.
can see that there is a marked disc bulge with marked left side neural exit foraminal narrowing, and it causes cecal sac compression, and there is evidence also of the nerve root appear to be aggregated, and also I can see that there is evidence of mild ligamentum flavum hypertrophy. I couldn't see that there is evidence. Yes, and also there is evidence of facet osteoarthropathy. At this level also I can see it is the same finding with compression of the cecal sac and aggregation of the nerve root. From here it appears to be normal, and there is wide neural exit foramina and the nerve root appearing normal. So this is my main concern. This patient could develop coda equina syndrome, so this is an emergency. I want to convey my finding urgently for the neurosurgical team for appropriate management and the treatment for this patient.
Okay. So, do you think you have to? So, yeah, okay, all right. So let's go with the, how to see MRI. We are starting with the basic. Whenever MRI is given to you in UK, how their students are learning is they have been taught that first sequence should be this, second sequence should be that. If you have seen T2 first, you have to check the stir second to look out for any important safety finding. Safety finding here are two, always in case of the spine. First is coda equina, as you said, another is infection. So here,
Okay.
if you could see, if you have seen the stir image, there is a facet joint infection over here.
Infection.
This is
Okay.
the facet joint septic arthritis,
Okay.
which is causing a lot of problem. Gradually, I told you, gradually increasing just over 2 months. If it could have
Okay.
been disc, it could be sometimes sudden, it could be sometimes gradually increasing over a long time, or it can be variable. But whenever I'm saying this kind of, very short timeline, you always think of any neoplasm, maybe some metastasis or infection. This three things you have to always rule out whenever you are looking at the spinal MRI. So in UK, they have specific sequence or specific system to look at everything. So first T2 sedge, then stir sedge, and then T2 axial to look for anything else. So first you have to rule out whether there is any process within the marrow going on, whether there is any process within the infective process going on or not, and then you should move ahead. So and that was the only mistake, which was a big mistake which you made. Otherwise, everything was fine. You were not looking at it. So this eye you have to develop. There was something over here in that region. You scrolled it many a time. So always look for paraspinal muscles and psoas muscle to avoid infection, missing the infection. This is the important thing which I would like to tell. Then you can say that, this is a infection and I would like to immediately call the spinal team. This is emergency and we need to manage this patient urgently with the spinal team.
Okay.
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 You getting my point where the
Yes.
problem was? Because we
Yes.
don't have, again, that's the problem. We are very nice radiologists. We are thinking from our mind. Our mind is developed in certain way, but we need to train it like a robot so that we don't miss anything.
Okay.
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 That's the learning point from this. So now we are going towards next case for you. And this is again spine.
Okay.
Number spine. The patient is having gradually increasing